Welcome to the Deep Dive, where we cut through the noise to bring you the most essential insights. Today, we're embarking on a crucial journey, a really deep dive into one of the most foundational yet, well, often incredibly complex regions of the human body, the pelvis and perineum.
That's right.
You might think of it as simply the lower trunk, but for elite professionals, this area is a remarkably intricate, multifunctional crossroads, absolutely essential for everything from structural support and waste elimination to reproduction.
Mm.
Our mission today is to really unpack its architecture and profound significance, distilling the most important nuggets of knowledge so you, the listener, can master this information.
Indeed. It's a region where so many critical systems converge in, well, a relatively confined space.
Wow.
We've pulled together extensive sources, detailed anatomical breakdowns covering bones, ligaments, muscles, viscera, nerves, and blood supply, all woven with, really fascinating clinical insights. We're here to guide you through this dense material, helping you understand not just what is there, but why it matters, making those surprising connections that truly elevate your understanding.
That's right. We want you to emerge from this deep dive with a comprehensive, elite professional level of understanding without feeling overwhelmed. We'll start by clearly defining these regions, kind of setting the stage, and then systematically build up our knowledge layer by layer.
Okay.
So the bony framework, the supporting structures, the vital organs housed within, and how everything is intricately wired and supplied. And we'll continuously highlight key clinical applications and challenges, showing you precisely why this knowledge is so crucial for real-world understanding.
Okay, so let's begin by defining our landscape. When we talk about the pelvis and perineum, we're referring to two interrelated regions associated with the pelvic bones and the terminal parts of the vertebral column. Let's first focus on the pelvis itself, which we can think of as the body's central hub for many vital functions.
Right, the central hub. As our central hub, the pelvis is, a fascinating space. It essentially contains and supports elements from three major systems: the urinary system, the gastrointestinal system, and the reproductive system. Its primary role is to cradle and protect organs like the bladder, the rectum, the anal canal, and the various reproductive tracts. But it's not just one undifferentiated space, is it? Anatomists divide the pelvis into two key regions, which helps us understand its structure and function much better.
Precisely. First, we have the false pelvis, sometimes referred to as the greater pelvis. This is the more superior region, primarily related to the upper parts of the large flaring pelvic bones and the lower lumbar vertebrae, which are, the bones of your lower back.
Right.
It's generally considered part of the abdominal cavity, providing bony support for the lower abdomen. The fan-shaped upper part of the ilium, which is the largest of your hip bones, forms its bony support and provides crucial attachment points for many of the muscles that move your lower limbs.
Okay. And then below that, we find the true pelvis, or the lesser pelvis. This is the inferior region directly related to the inferior parts of the pelvic bones, the sacrum, that triangular bone at the base of your spine, and the coccyx, or tailbone.
Yes.
This true pelvis is critical because it has a distinct entrance, or inlet, and an exit, or outlet. The bowl-shaped pelvic cavity, which is what we usually refer to when discussing the pelvic organs, is enclosed by this true pelvis. It's continuous superiorly with the abdominal cavity, and the portion of the ilium that lies inferior to a specific landmark called the arcuate line is what truly contributes to the walls of this deeper true pelvis.
Now, if we shift our focus slightly downwards, we encounter the perineum, which you can imagine as the inferior gateway to this entire region. It lies directly inferior to the muscular floor of the pelvic cavity, and its boundaries literally form the pelvic outlet, making it a distinct diamond-shaped space positioned between your lower limbs.
So what does this inferior gateway contain then?
Well, the perineum specifically houses the external genitalia, along with the external openings of both the genitourinary and gastrointestinal systems. Crucially, it's distinctly separated from the pelvic cavity above by the pelvic floor, which acts like a muscular diaphragm.
Okay.
A key function of the perineum is to anchor the roots of the external genitalia, both the clitoris in women and the penis in men, to the bony margin of the anterior half of the pelvic outlet and a thick, fibrous structure known as the perineal membrane.
Right, that membrane is important.
It is. And these roots themselves are composed of erectile, vascular tissues, and their associated skeletal muscles, providing both structural integrity and, of course, the capacity for sexual function in this vital region.
Okay, so having defined the overall landscape, let's now lay the groundwork with the very bedrock of this region, the bony framework. This involves the pelvic bones, the sacrum, and the coccyx. Understanding these structures is, well, foundational for truly grasping the intricate anatomy that follows.
Absolutely fundamental.
When we talk about what most people call the hip bone, what's truly fascinating for an elite professional to understand is that each pelvic bone isn't a single entity at birth. It's actually formed by three distinct elements: the ilium, the pubis, and the ischium. Think of them as individual pieces of a puzzle.
Right.
At birth, they're connected by cartilage, primarily in the area of the acetabulum, that deep socket that cradles your hip joint. These three bones then progressively fuse into a single strong bone, usually between the ages of 16 and 18. This developmental process really highlights the robust nature of this structure once fully mature.
Precisely. This fusion creates a remarkably strong ring. On the medial surface of each fused pelvic bone, you'll find an oblique line. This line serves as a crucial anatomical divider, separating the superior region, which forms the lateral wall of the false pelvis, from the inferior region, which contributes to the lateral wall of the true pelvis. The lower two-thirds of this oblique line, specifically, form what we call the linea terminalis, and it's a vital component of the margin of the pelvic inlet, essentially the entrance to the true pelvic cavity.
Got it. Then, on the lateral surface of the pelvic bone, you have the prominent acetabulum, that large, cup-shaped articular socket that forms the hip joint by articulating with the head of the femur.
The hip socket.
Exactly. Just inferior to the acetabulum, there's the large obturator foramen. This opening is mostly closed by a fibrous sheet called the obturator membrane, but a small channel, the obturator canal, remains superiorly. This canal is a critical communication pathway, allowing the obturator nerve and vessels to pass between the lower limb and the pelvic cavity.
Yeah, that's a key passageway. Looking at the posterior margin of the pelvic bone, we find a sequence of important landmarks. There's the greater sciatic notch, a deep indentation, which is separated from the smaller, lesser sciatic notch by a sharp, palpable projection known as the ischial spine.
That spine is really prominent.
It is. And this entire margin then terminates inferiorly in the large, roughened ischial tuberosity, literally what you're sitting on right now, bearing your body weight. On the anterior margin, you'll find the anterior superior iliac spine, the anterior inferior iliac spine, and the pubic tubercle. These are all crucial attachment points for muscles and ligaments, and easily identifiable landmarks for clinicians.
Let's delve a bit deeper into each of these three bones, starting with the ilium. This is the most superior and largest component of the pelvic bone. Its upper part, often called the wing, is a flat, fan-shaped structure. It provides crucial bony support for the lower abdomen, the false pelvis, and serves as a broad attachment site for numerous powerful lower limb muscles.
Right.
The concave anteromedial surface of the wing forms the iliac fossa, while its external or gluteal surface is marked by lines and roughenings where the gluteal muscles attach.
Running along the thickened superior margin of the ilium is the iliac crest. This is a major, easily palpable landmark that serves as an extensive attachment site for muscles and fascia of the abdomen, back, and lower limb. It terminates anteriorly as the anterior superior iliac spine and posteriorly as the posterior superior iliac spine.
The ACEs and PSIs.
Exactly. Near the anterior end of the crest, there's a prominent lateral projection called the tuberculum of the iliac crest, and the posterior end of the crest thickens into the iliac tuberosity. Just inferior to the anterior superior iliac spine is the anterior inferior iliac spine, which provides an attachment for the rectus femoris muscle and the strong iliofemoral ligament.
Okay.
A less prominent posterior inferior iliac spine is found along the posterior border of the sacral surface, forming the superior margin of the greater sciatic notch. The medial surface of the ilium also features a sharp ridge posteriorly, superior to the sacral articulation, and anteriorly the rounded arcuate line, which is a part of both the linea terminalis and the pelvic brim.
For an elite professional, here's a crucial clinical connection. The iliac crest is a common and easily accessible site for bone marrow biopsies. When assessing conditions like leukemia, its superficial position and palpable nature make it an ideal and, well, relatively safe location for obtaining a bone marrow sample, highlighting the practical utility of knowing these superficial landmarks.
That's a really important clinical point. Moving on to the pubis, this bone forms the anterior and inferior part of the pelvic bone. Its body is flattened dorsoventrally and articulates with the pubic bone of the opposite side at the pubic symphysis.
The midline joint.
Exactly. On its superior surface, it has a rounded pubic crest that extends laterally to a prominent bump, the pubic tubercle. The superior pubic ramus projects post-prolaterally from the body, eventually joining the ilium and ischium. Its sharp superior margin, called the pecten pubis or pectineal line, is another important component of the linea terminalis and the pelvic inlet. The inferior surface of this ramus contains the obturator groove, which forms the upper margin of the obturator canal. Lastly, the inferior ramus projects laterally and inferiorly to join with the ischoramus, completing the obturator foramen.
And finally, rounding out the trio is the ischium, which forms the posterior and inferior part of the pelvic bone. It has a large body that projects superiorly to join the ilium and the superior ramus of the pubis, and a ramus that projects anteriorly to join the inferior ramus of the pubis. On its posterior margin, that prominent ischial spine we mentioned earlier is clearly visible, serving as a critical landmark that separates the lesser sciatic notch below from the greater sciatic notch above. And of course, the ischial tuberosity is its most prominent feature, a large roughened area on the postero-inferior aspect. This tuberosity is vital not only for the attachment of many powerful lower limb muscles, but also, as we noted, for supporting your body weight when you're sitting.
The sit bones. With the individual pelvic bones covered, let's now turn to the sacrum, which forms the critical posterior foundation of the spine within the pelvis. It's distinctively shaped like an inverted triangle, resulting from the fusion of 5 sacral vertebrae, usually by early adulthood.
Right.
Its broad base articulates superiorly with the 5th lumbar vertebra, or L5, at the lumbosacral joint, providing a strong connection to the rest of the vertebral column. Its narrower apex articulates with the caucasus. Laterally, its L-shaped articular facets engage with the ilium to form the very stable sacroiliac joints.
On the superior surface of the sacrum, you'll observe the body of vertebra S1 flanked by expanded wing-like transverse processes called the ala. The anterior edge of the S1 vertebral body projects forward as the sacral promontory, which is a crucial anatomical landmark, especially for measurements of the pelvic inlet during obstetrics.
Yeah, that promontory is key. The sacrum exhibits a concave anterior surface and a convex posterior surface, contributing to the natural curvatures of the spine. It is punctuated by 4 pairs of anterior sacral foramina on its anterior surface, which allow the anterior rami of the S1 to S4 spinal nerves to exit.
Okay.
Similarly, 4 pairs of posterior sacral foramina are present on the posterior surface, transmitting their corresponding posterior rami. Internally, the sacral canal is a continuation of the vertebral canal, housing the lower spinal nerves, and it terminates inferiorly as the sacral hiatus, important landmark for caudal anesthesia.
Okay, for epidurals and things.
Exactly.
Finally, we have the coccyx, commonly known as the tail dome. This is the small fused terminal part of the vertebral column, typically composed of 4 fused coccygeal vertebrae, also in an inverted triangle shape. Its base is directed superiorly with a small facet for articulation with the sacrum. 2 small, upward projecting horns, or cornua, are present, which articulate or sometimes fuse with the sacral cornua. The first coccygeal vertebra also has small rudimentary transverse processes. What's interesting for an elite professional is that vertebral arches are notably absent here, meaning there's no bony vertebral canal within the coccyx itself, reflecting its kind of vestigial nature.
Right, no real canal there. Now that we've built the bony house, the next crucial step is to understand how all these elements are held together. This brings us to the articulations and stability. Pelvic joints. The stability of the pelvis is paramount for weight bearing and locomotion, and is achieved through a fascinating interplay of joints and, well, really powerful ligaments.
First, let's look at the lumbosacral joints. These are the connections between your last lumbar vertebra, L5, and the sacrum. They're actually quite complex, composed of 2 zygapophyseal joints. These are the synovial joints between the articular processes and an intervertebral disc that firmly joins the bodies of L5 and S1. For an elite professional, a key insight here is the unique angulation. The sacrum is angled posteriorly on L5, which means the anterior part of that L5-S1 intervertebral disc is naturally thicker than its posterior part. This angle is fundamental to the lumbar curvature and overall spinal biomechanics.
That unique angulation is certainly a defining feature. These joints are further reinforced by incredibly strong iliolumbar and lumbosacral ligaments. The iliolumbar ligaments extend from the transverse processes of L5 to the ilium, providing lateral stability.
Okay.
The lumbosacral ligaments, on the other hand, connect L5 to the sacrum. Together, these ligaments provide robust stability to this critical junction, which bears a significant amount of the upper body's weight.
Next, we have the sacroiliac joints. These joints are incredibly important because their primary function is to transmit the immense forces generated from your lower limbs directly up to your vertebral column, making them central to bipedal posture and movement.
Absolutely central.
They are synovial joints found between the L-shaped articular facets on the lateral surfaces of the sacrum and the corresponding facets on the iliac parts of the pelvic bones. To achieve such profound stability, their articular surfaces have a highly irregular contour and actually interlock, which strongly resists movement.
Yeah, they really lock together.
In fact, for many individuals, these joints undergo degenerative changes over time, often becoming fibrous or even completely ossified with age, reflecting their weight-bearing demands.
Their formidable stability is further enhanced by three key sets of ligaments. The anterior sacroiliac ligament is a thickening of the joint capsule, running anteriorly and inferiorly. The interosseous sacroiliac ligament is particularly noteworthy as the largest and strongest of these ligaments. It's positioned immediately posterior-superior to the joint, filling the gap between the bones.
Wow, that sounds strong.
It really is. Finally, the posterior sacroiliac ligament covers the interosseous ligament, completing this dense network. This complex ligamentous arrangement highlights the critical role of this joint in stabilizing the entire pelvic girdle.
For an elite professional, here's a critical clinical insight. The sacroiliac joints are not only susceptible to pain from simple degenerative changes, but they are also a common site for inflammatory conditions, particularly those known as seronegative spondyloarthropathies, such as ankylosing spondylitis, psoriatic arthritis, or inflammatory arthritis associated with inflammatory bowel disease.
Right, the seronegatives.
Exactly. These conditions can cause specific and often chronic inflammatory changes within these joints, leading to significant diagnostic challenges and a need for precise imaging and clinical evaluation.
Shifting our focus to the anterior aspect of the pelvis, we find the pubic symphysis joint. This is a midline joint located between the adjacent surfaces of the two pubic bones. Each articulating surface is covered by a thin layer of hyaline cartilage, but they are linked across the midline by a robust pad of fibrocartilage.
So not bone on bone directly.
That fibrocartilage is key. This entire joint is then surrounded and reinforced by interwoven collagen fibers. It's supported superiorly by the superior pubic ligament and inferiorly by the inferior pubic ligament. While it appears to be a rigid joint, the pubic symphysis, particularly in women, undergoes subtle but significant changes during pregnancy and childbirth, allowing for a slight degree of expansion that can be crucial during vaginal delivery.
Ah, interesting. Now let's talk about something that highlights the inherent vulnerability of this bony ring: pelvic fractures. For an elite professional, understanding the pelvis as a series of interconnected rings is absolutely critical. We have 3 bony rings, the pelvic inlet and the 2 obturator foramina, and 4 fibro-osseous rings, the greater and lesser sciatic foramina formed by ligaments. The key concept, often referred to as the brittle nature of the bony rings, is that a fracture on one side almost always implies a second fracture somewhere else in the ring. You rarely get an isolated break.
This is a profoundly important clinical insight. Pelvic fractures are rarely simple and usually occur in high-impact trauma. The clinical significance of this ring of vulnerability is immense. Because the pelvis has such large bony surfaces and is richly vascularized, a fracture can lead to massive, life-threatening bleeding, producing a large hematoma.
That's scary.
It can be. This rapid blood loss can quickly reduce circulating blood volume, leading to hypervolemic shock if not aggressively managed. Furthermore, pelvic fractures can directly disrupt the vital organs contained within, causing urethral disruption, potential bowel rupture, and nerve damage, all contributing to exceptionally high morbidity and mortality if not diagnosed and treated promptly.
Wow. Okay, so we've established the sturdy framework and how it's all held together. Next, let's explore the gates of the pelvis, the inlet and outlet. These are the critical apertures through which structures enter and exit the true pelvic cavity, with profound implications, especially in obstetrics.
Exactly. The pelvic inlet is the superior aperture of the true pelvis. In men, it's typically described as heart-shaped, while in women, it tends to be more circular. This difference is largely due to a less distinct sacral promontory and broader allay of the sacrum in women, anatomical adaptations that have significant implications for childbirth.
Right, facilitating birth.
Precisely. This inlet is completely ringed by bone, forming a rigid and unyielding boundary.
And its borders are precisely defined. Posteriorly, it's the body of vertebra S1, specifically the sacral promontory. Laterally, you have the LA of the sacrum and a prominent, sharp rim on the pelvic bone. Anteriorly, it's completed by the pubic symphysis. Numerous vital structures pass through this inlet, including major vessels, nerves, lymphatics, the sigmoid colon, and the ureters, effectively connecting the abdominal cavity with the pelvic cavity. In men, the ductus deferens also traverses this space, while in women, the ovarian vessels, nerves, and lymphatics to the ovaries pass through here.
For an elite professional, understanding the pelvic inlet is absolutely critical in obstetrics. During childbirth, the fetus must navigate this inlet as it descends from the abdomen into the true pelvis. Both the sagittal diameter and the maximum transverse diameter of the inlet are crucial measurements that help predict the feasibility of a vaginal delivery.
Okay.
In the anatomical position, the pelvic inlet is angled 50 to 60 degrees forward relative to the horizontal plane, facing anterosuperiorly, which further influences the birthing process.
Then we have the pelvic outlet, which is the inferior opening of the true pelvis. Unlike the inlet, this is a diamond-shaped aperture formed by both bone and strong ligaments. Its borders are also quite specific. Anteriorly in the midline, it's the pubic symphysis. Laterally, for the anterior half, the inferior margin of the pelvic bone projects posteriorly and laterally to the ischial tuberosity, forming the pubic arch.
Right.
Posteriorly, the strong sacrotuberous ligament continues this margin from the ischial tuberosity all the way to the coccyx and sacrum.
These precise boundaries mean that the pubic symphysis, the ischial tuberosities, and the coccyx are all palpable landmarks, providing vital reference points for clinical examination. Structures that pass through this outlet include the terminal parts of the urinary and gastrointestinal tracts, and in women, the vagina.
And the orientation differs too, right?
It does, interestingly. The urogenital part of the outlet, defined by the pubic arch, is nearly horizontal, while the posterior anal triangle part is more vertically oriented, reflecting the different functions of these two regions.
For an elite professional in obstetrics, here's a key insight. The bispinous outlet, which is the distance between the two ischial spines, and the sagittal outlet, measured from the coccyx to the inferior pubic symphysis, are absolutely crucial measurements for predicting the success of a vaginal delivery.
Absolutely.
Today, MRI is often employed to obtain these precise measurements, carrying no radiation risk to the fetus or mother, which is, a significant advancement in obstetric care.
A huge advantage. Now that we've navigated the gates, let's explore the structures that form the internal architecture. The walls and floor, which provide crucial support and containment to the pelvic viscera. This is where muscles and ligaments truly shape the cavity.
The pelvic walls themselves are predominantly composed of bone, muscle, and a complex network of ligaments. These walls are formed by the sacrum, the coccyx, and the inferior halves of the pelvic bones. But it's the ligaments that are truly remarkable, as they do more than just connect bones. They convert bony notches into crucial foramina.
Yes, they create passages.
For instance, the sacrospinous ligament is a triangular ligament that runs from the ischial spine to the lateral sacrum and coccyx. And the sacrotuberous ligament, which is larger and more superficial, has a broad attachment from the superior iliac spine, the dorsal and lateral sacrum, and the dorsolateral coccyx, converging to attach to the medial ischial tuberosity.
These powerful ligaments are anatomical marvels. Their primary function is to stabilize the sacrum on the pelvic bones, resisting any upward tilting, which is essential for maintaining the integrity of the pelvic girdle during weight bearing. Critically, these two ligaments, the sacrospinous and sacrotuberous, work together to transform the greater and lesser sciatic notches on the pelvic bones into distinct greater and lesser sciatic foramina, creating vital pathways for nerves and vessels to exit and enter the pelvis.
Ah, okay. So they complete those openings. Within these walls, we find two key muscles. First, the obturator internus muscle. This is a flat, fan-shaped muscle that originates from the deep surface of the obturator membrane and the surrounding pelvic bone, effectively forming a large part of the anterolateral wall of the pelvic cavity. Its tendon then makes a distinct 90-degree bend around the ischium, exiting the pelvis through the lesser sciatic foramen to act on the hip joint, primarily as a lateral rotator of the thigh.
Then there's the piriformis muscle, which is triangular in shape and originates from the bridges of bone between the anterior sacral forama. It forms a large part of the posterolateral pelvic cavity wall. This muscle is particularly significant because it passes laterally through the greater sciatic foramen to insert on the greater trochanter of the femur above the obturator internus.
Right.
Crucially, the piriformis muscle divides the greater sciatic foramen into two distinct regions, a smaller suprapiriform aperture and a larger infrapiriform aperture, each allowing specific nerves and vessels to pass through.
So these apertures in the pelvic wall are absolutely critical communication points. The obturator canal, located at the superior aspect of the obturator foramen, transmits the obturator nerve and vessels, allowing communication between the pelvis and the adductor region of the thigh. The greater sciatic foramen is a major conduit for structures heading to the lower limb. It's formed by the greater sciatic notch and those strong sacrospinous and sacrotuberous ligaments. As you mentioned, the piriformis muscle divides it. Above the piriformis, you find the superior gluteal nerves and vessels, and below it, a veritable highway of structures, including the inferior gluteal nerves and vessels, the massive sciatic nerve, the pudendal nerve, and the internal pudendal vessels. It's crowded down there.
It certainly is. And then the lesser sciatic foramen provides a crucial, albeit narrower, communication pathway between the gluteal region and the perineum, situated inferior to the pelvic floor. It transmits the tendon of the obturator internus muscle. For an elite professional, a key insight here is that the pudendal nerve and internal pudendal vessels actually perform a remarkable loop. They first exit the pelvis via the greater sciatic foramen, then curl around the ischial spine and sacrospinous ligament, only to re-enter the perineum through this lesser sciatic foramen.
Wow, that's quite the detour.
It's a complex but highly efficient anatomical detour, ensuring these vital neurovascular structures reach their destination in the perineum.
That's fascinating. Now, let's get to the true heart of this region. The pelvic floor, which is aptly called the diaphragm of the pelvis. This is a dynamic fibromuscular structure formed by layers of muscles and fascia, and it's what separates the pelvic cavity above from the perineum below.
The muscular component of the pelvic floor is known as the pelvic diaphragm. It's bowl or funnel-shaped and is attached superiorly to the pelvic walls. It primarily consists of two large levator ani muscles and two smaller coccygeus muscles.
Okay.
Its circular line of attachment to the pelvic wall on each side runs between the greater and lesser sciatic foramina. Critically, in its anterior region, there's a U-shaped defect called the urogenital hiatus, which is an opening that allows passage of the urethra in both men and women and the vagina in women. The anal canal also passes through a posterior, more circular orifice in the pelvic diaphragm.
Let's focus on the levator ani muscles, which are the largest and most significant components of this pelvic diaphragm. They have a broad origin. From the posterior aspect of the pubic bone, a tendinous arch that spans across the obturator internus fascia, and from the ischial spine.
Right. Quite a wide origin.
From these origins, their fibers course downwards and medially. At the midline, they insert posterior to the vagina in women and around the anal aperture in both sexes. Posterior to the anal aperture, these muscles blend to form the anococcygeal ligament, which then attaches to the coccygeus.
For an elite professional, the subdivisions of the levator ani are crucial. The pubococcygeus originates from the pubis and courses posteriorly toward the coccygeus, and itself can be subdivided into the puboprostaticus in men, supporting the prostate, the pubovaginalis in women, and the puboralis. But the most functionally significant part is the puborectalis.
Yes, the sling.
Exactly, the puborectalis sling. This powerful muscle also originates from the pubis, but forms a distinctive U-shaped sling around the terminal part of the gastrointestinal tract, specifically the anorectal junction.
Here's a brilliant piece of biological engineering for everyday function. The puborectalis sling is what maintains the perineal flexure, an angle of approximately 90 degrees at the anorectal junction. This angle effectively acts as your body's natural pinch valve, crucial for maintaining fecal continence.
Absolutely crucial.
When you are ready to defecate, this muscle consciously relaxes, which then increases that anorectal angle to about 130 to 140 degrees, allowing for the easier passage of feces. It's a beautifully simple yet profoundly effective mechanism for bowel control.
Indeed. The final component of the levator ani is the ileococcygeus, which originates from the fascia covering the obturator internus muscle and joins its partner in the midline to form a raphe from the anal aperture to the coccyx. Collectively, the functions of the levator ani muscles are vital. They support the pelvic viscera, they maintain that critical anorectal angle, and they reinforce the external anal sphincter.
And the vaginal sphincter in women.
And the vaginal sphincter in women, yes. These muscles are innervated by direct branches from the anterior ramus of the S4 spinal nerve, and also by the inferior rectal branch of the pudendal nerve,
Right.
S2, S4.
Complementing the levator ani are the two smaller coccygeus muscles. These are triangular muscles that overlie the sacrospinous ligaments, completing the posterior part of the pelvic diaphragm. Their apices attach to the ischial spines, and their broader bases attach to the lateral coccyx and the adjacent sacrum.
Mm-hmm.
They receive innervation from direct branches of the anterior rami of the S3 and S4 spinal nerves. Their functions include providing additional support to the posterior pelvic floor and, quite specifically, pulling the coccygus forward after defecation.
Now, supporting the anterior pelvic floor, particularly in the urogenital triangle, we find the perineal membrane and deep perineal pouch. The perineal membrane is a thick, triangular sheet of fascia that effectively fills the space between the arms of the pubic arch. It has a distinctive free posterior border, which is anchored firmly to the central perineal body, and it's oriented in a nearly horizontal plane. There's a small gap anteriorly between the membrane and the inferior pubic ligament, which allows passage for the deep dorsal vein of the penis or clitoris.
And just superior to that perineal membrane is the deep perineal pouch, which is a narrow compartment-like region. It contains a crucial layer of skeletal muscle, along with various neurovascular elements. What's important for an elite professional to understand is that it's open superiorly, meaning it's not completely separated from more superior structures by a distinct fascial layer, and therefore it directly contributes to overall pelvic floor support.
That's a key point, the superior opening.
The urethra penetrates a circular hiatus in this pouch in both men and women, and in women, the vagina also passes through a distinct hiatus posterior to the urethra.
Within this deep perineal pouch, the muscles primarily function as sphincters for the urethra and as stabilizers for the perineal membrane. This includes the external urethral sphincter, a skeletal muscle that surrounds the membranous urethra. In women, there are two additional specialized muscles: the sphincter urethrovaginalis, which surrounds both the urethra and the vagina as a single unit, and the compressor urethra, which originates from the ischiopubic rami and meets anterior to the urethra.
Helping with closure.
Exactly. Both assist in the voluntary closure of the urethra. Additionally, the deep transverse perineal muscles, a pair of muscles on each side, run parallel to the posterior margin of the perineal membrane and join at the midline to help stabilize the perineal body. All of these muscles within the deep perineal pouch are innervated by the perineal branches of the pudendal nerve, originating from spinal cord segments S2 to S4.
Okay, let's turn our attention to the perineal body, which is also known as the central tendon of the perineum. For an elite professional, this is a somewhat poorly defined yet incredibly important fibromuscular node located right at the center of the perineum, approximately midway between the two ischial tuberosities. Think of it as a central attachment point, a literal crossroads where a multitude of muscles from both the pelvic floor and the perineum intersect and firmly attach.
Indeed. Converging here are the critical levator ani muscles of the pelvic diaphragm, as well as several muscles from both the urogenital and anal triangles. This includes the skeletal muscle sphincters of the urethra, vagina, and anus, the deep transverse perineal muscles, the external anal sphincter, the superficial transverse perineal muscles, and the bulbospongiosus muscles.
Wow, a lot connects there.
It really does. Even the posterior end of the urogenital hiatus in the levator ani muscles has connective tissue that integrates with the perineal body. Its integrity is fundamental to pelvic floor function.
Here's a critical clinical insight for you. The perineal body is subjected to immense stretching and can even be torn during childbirth. Historically, an episiotomy, a surgical incision into the perineal body, was routinely performed to prevent traumatic, uncontrolled tearing. However, more recent evidence and a thorough review of data now suggests that routine episiotomy does not actually decrease pelvic floor damage, leading to a significant shift in modern obstetric practice towards more conservative management unless clinically indicated.
Yeah, practice has really changed there. Now that we've built the walls and floor, let's zoom in on the external landscape of this region, focusing on the perineum in detail, triangles and fissures.
As we mentioned, the perineum is that diamond-shaped region located inferior to the pelvic floor, nestled between your thighs. Its outer peripheral boundary is actually formed by the pelvic outlet itself, which we discussed earlier. The ceiling of the perineum is formed by that crucial muscular layer, the pelvic diaphragm, those levator ani and coccygeus muscles. Its narrow lateral walls are simply the walls of the pelvic cavity that extend below the attachment points of the levator ani muscles.
The external boundaries of the perineum are easily identifiable through palpation. Anteriorly, it's defined by the inferior border of the pubic symphysis. Posteriorly, it extends to the tip of the coccyx, and laterally you can feel the prominent ischial tuberosities.
The sit bones again.
Exactly. The lateral margins are further formed by the ischiopubic rami anteriorly and the sacrotuberous ligaments posteriorly. What's crucial for understanding the perineum is that an imaginary line drawn horizontally between the two ischiotuberosities divides it into two distinct and functionally different triangles.
Exactly. Anteriorly, we have the urogenital triangle, which is associated with the external openings of the urinary and reproductive systems and serves to anchor the external genitalia. This triangle in the anatomical position faces inferiorly and is oriented in a nearly horizontal plane. Posteriorly, we find the anal triangle, which, as its name suggests, contains the anus and the external anal sphincter. This triangle faces more posteriorly and is tilted slightly upward. For an elite professional, knowing that the major nerve and artery of this entire perineal region are the pudendal nerve, S2, S4, and the internal pudendal artery is absolutely fundamental.
Absolutely key neurovasculature. Next, let's explore the ischioanal fossa and anterior recesses. Because the levator ani muscles course medially from the lateral pelvic walls towards the anal aperture, they create inverted wedge-shaped gutters. These gutters, one on each side of the anal aperture within the anal triangle, are the ischioanal fossa.
Okay.
These spaces are uniquely filled with fat, which is critically important because it allows for the necessary movement and expansion of the anal canal during defecation without causing undue stress or tearing.
So the fat acts like padding.
Essentially, yes. It allows for expansion. The walls of these fossae are quite defined. The lateral wall is formed by the ischium, the obturator internus muscle, and the sacrotuberous ligament, while the medial wall is formed by the levator ani muscle. Furthermore, for an elite professional, it's important to recognize that these fossae are continuous anteriorly with recesses that project into the urogenital triangle, extending superior to the deep perineal pouch. This anatomical continuity has clinical implications for the spread of infection. This brings us to a crucial clinical insight. The anal mucosa is particularly vulnerable to injury. Infection from conditions like anal gland inflammation or fistulas can spread readily into these fat-filled ischioanal fossae, leading to the formation of painful and often extensive abscesses. Understanding the boundaries and contents of these spaces is paramount for accurate diagnosis and surgical drainage of such conditions.
Shifting to the anal triangle, which is the posterior region of the perineum, it faces postero-inferiorly in the anatomical position. Its boundaries are precisely defined, laterally by the strong sacrotuberous ligaments, anteriorly by that imaginary line between the ischial tuberosities, and posteriorly by the tip of the coccyx. Its major feature, positioned centrally within its confines, is the anal aperture, which is flanked on either side by those fat-filled ischioanal fossa.
The primary muscle controlling the anal aperture is the external anal sphincter, a skeletal muscle that surrounds the anal canal and normally keeps it firmly closed, providing voluntary control over defecation. For an elite professional, it's helpful to know it has three functional parts: a deep part, which is a thick ring that blends superiorly with the levator ani muscles; a superficial part, which encircles the anal canal and is anchored anteriorly to the perineal body and posteriorly to the anacoccygeal ligament; and a subcutaneous part, a horizontally flattened disc situated just beneath the skin.
So it's quite complex.
It is. This entire external anal sphincter is innervated by the inferior rectal branches of the pudendal nerve, as well as direct branches from the S4 spinal nerve.
Here's a crucial clinical insight for a very common condition: hemorrhoids. These are essentially engorgements or varicose veins of the venous plexuses located at or inside the anal sphincter. They can be classified as external hemorrhoids occurring at the anal verge and covered by skin, or internal hemorrhoids which originate inside the rectum above the pectinate line and tend to bleed, often prolapsing with straining.
Right.
Factors like chronic straining during defecation, obesity, and a sedentary lifestyle are known contributors. For clinicians, it's absolutely vital to differentiate hemorrhoids from other, more serious conditions, such as colorectal tumors, as their symptoms can sometimes overlap.
A very important differential. Moving to the urogenital triangle, this is the anterior half of the perineum, and unlike the anal triangle, it's oriented in a nearly horizontal plane, facing inferiorly. It's precisely defined laterally by the ischiopubic rami, posteriorly by the imaginary line connecting the ischial tuberosities, and anteriorly by the inferior margin of the tudic symphysis. Its roof, like the anal triangle, is formed by the levator ani muscles of the pelvic diaphragm.
A key difference from the anal triangle is the strong fibromuscular support platform provided by the perineal membrane and the deep perineal pouch. Between that perineal membrane and a deeper membranous layer of superficial fascia, we find the superficial perineal pouch. This pouch is a critical space because it houses the erectile tissues and their associated skeletal muscles, which are fundamental to external genitalia function.
The superficial fascia, of the urogenital triangle, often referred to as Collis's fascia, is a dense membranous layer with very specific and clinically important attachments. Posteriorly, it's firmly attached to the posterior border of the perineal membrane, which means it absolutely does not extend into the anal triangle.
Okay, that's a sharp boundary.
It is. Laterally, it's attached to the ischiopubic rami, preventing it from extending into the thigh. Crucially, it is continuous superiorly with the membranous layer of the superficial fascia of the anterior abdominal wall.
For an elite professional, here's a critical clinical insight tied to these fascial planes. A urethral rupture. If the proximal spongy urethra, for instance, is torn due to a straddle injury, urine will extravasate into the superficial perineal pouch. Because of the precise attachments of Collis fascia, this urine will then track down into the scrotum and can extend up onto the anterior abdominal wall, deep to the superficial fascia, but it will not spread into the anal triangle or down into the thigh.
Fascinating how the fascia dictates the spread.
Exactly. Conversely, a rupture at the prostatomembranous junction, often caused by a severe pelvic fracture, will result in urine extravasating into the true pelvis. Severe pelvic injuries can even disrupt the puboprostatic ligaments, potentially leading to the prostate dislocating superiorly. Understanding these fascial compartments is absolutely essential for accurate diagnosis and management of such injuries.
Within this urogenital triangle, we find the crucial erectile tissues. These are specialized vascular structures that form the external genitalia. They comprise the corpora cavernosa, a pair of cylindrical structures. Their roots, called crura, are firmly anchored to the pubic arch, while their distal ends come together to form the body of the clitoris in women, or the dorsal parts of the body of the penis in men.
Okay. In women, we also have the bulbs of the vestibule, which are a pair of elongated erectile structures located on each side of the vaginal opening, anchored to the perineal membrane. These are connected anteriorly by small bands of erectile tissue to the glans clitoris, that single, small, P-shaped erectile mass at the very end of the clitoral body, positioned anterior to the urethral opening.
In men, the structural equivalents of the bulbs of the vestibule and the glans clitoris are fused into a single, large erectile mass called the corpus spongiosum. It is anchored at its base to the perineal membrane. Its proximal end forms the ventral part of the body of the penis, and it spans distally to form the glans penis. A key distinction for an elite professional here is that this fusion in men means the urethra is entirely enclosed by the corpus spongiosum, opening at the tip of the penis, which contrasts sharply with the female anatomy where the urethra opens separately into the vestibule.
Right, a major difference. Associated with these erectile tissues are specific muscles located within the superficial perineal pouch. The ischiocavernosus muscles cover the crura of the penis or clitoris. These muscles are anchored to the ischial tuberosity and ramus, and they attach directly to the crus. Their primary function is to force blood from the crus into the body of the penis or clitoris, contributing significantly to erection.
Then there are the bulbus spongiosus muscles. In women, each muscle is anchored to the perineal body, covers the greater vestibular gland and bulb of the vestibule, and attaches to the bulb and perineal membrane, with some fibers arching over the clitoris. They function to compress the bulbs of the vestibule, thereby forcing blood into the glans clitoris.
Okay.
In men, these muscles are joined in a midline raphe on the inferior surface of the bulb of the penis and are anchored to the perineal body. They cover the bulb of the penis and attach to the perineal membrane and connective tissue of the bulb. In men, their functions are threefold. They compress the corpus spongiosum, forcing blood into the glands. They facilitate emptying residual urine from the urethra after urination. And their reflex contraction is responsible for the pulsatile emission of semen during ejaculation.
Quite versatile in men, then. Lastly, the superficial transverse perineal muscles are a pair of flat band-shaped muscles. They are attached to the ischial tuberosities and rami and extend medially to the perineal body. Their primary role is to help stabilize the position of the perineal body, reinforcing the central support structure of the perineum.
Now that we've explored the structural elements, let's delve into the viscera. Systems within the pelvis, where we find the terminal parts of the gastrointestinal, urinary, and reproductive systems intricately arranged and operating within this confined space. Understanding their relationships is crucial.
Kicking off with the gastrointestinal system, we'll focus on the rectum and anal canal. The pelvic parts of the GI system are the terminal end of the sigmoid colon, which transitions into the rectum, and then the anal canal.
The rectum is continuous superiorly with the sigmoid colon, typically at about the level of the third sacral vertebra, or S3, and inferiorly it narrows to become the anal canal. It is the most posterior of the pelvic viscera, lying immediately anterior to and following the concave contour of the sacrum.
Following the curve of the sacrum?
Exactly. For an elite professional, a key functional insight here involves the anorectal junction. This is pulled forward by the puborectalis muscle, which, as we discussed earlier, forms the perineal flexure, angling the anal canal posteriorly. This angle is absolutely essential for maintaining cecal continence.
That pinch valve again.
That's the one. Anatomically distinguishing the rectum from the colon, the rectum notably lacks tania coli, omental appendices, and the saculations, or haustra, typical of the large intestine. Its lower part expands to form the rectal ampulla, and it also exhibits three characteristic lateral curvatures.
Then we have the anal canal, which begins where the rectal ampulla narrows at the pelvic floor and terminates as the anus after passing through the perineum. It is surrounded along its entire length by two crucial sphincters, the internal anal sphincter, which is composed of smooth muscle and is therefore involuntary, and the external anal sphincter, which is skeletal muscle and provides voluntary control over defecation. Both are normally kept in a state of tonic contraction to maintain continence.
The lining of the anal canal presents distinct features that reflect its unique developmental transition from gastrointestinal mucosa to skin, and this has significant clinical implications. The upper part features longitudinally oriented mucosal folds called anal columns, which are united inferiorly by crescentic folds known as anal valves.
Okay.
Superior to each anal valves are depressions called anal sinuses. These anal valves collectively form the pectinate line, which marks the approximate position of the fetal anal membrane. Inferior to this, the anal pecten is a transition zone of non-keratinized stratified squamous epithelium, eventually giving way to the inocutaneous line, or white line, where the lining becomes true keratinized skin.
Here's a critical clinical insight. Colorectal cancer is a common and often lethal malignancy. For an elite professional, understanding its progression is key. Tumors typically develop from benign polyps within the colorectal mucosa. Prognosis depends heavily on the degree of tumor penetration through the bowel wall, the presence of lymphatic dissemination, and systemic metastases.
Right, staging is crucial.
Absolutely. Given the rectum's proximity to other vital pelvic organs like the uterus or bladder, accurate staging using advanced imaging modalities like CT, MRI, or endoscopic ultrasound is extremely important to assess local invasion and guide treatment strategies.
This leads us directly to the digital rectal examination, or DRE. This is a fundamental clinical procedure. A gloved finger is gently inserted into the rectum, allowing for palpation of the anal mucosa for any masses or irregularities. In women, this can also allow for palpation of the posterior vaginal wall and the cervix. In men, the prostate can be evaluated for nodules, masses, or changes in consistency.
A very informative exam.
Extremely. A DRE also helps detect fresh or altered blood, which can be a sign of various pathologies. It often serves as a crucial initial step, followed by more targeted investigations like proctoscopy, colonoscopy, or ultrasound-guided biopsy.
Now let's transition to the urinary system, focusing on the terminal ureters, the bladder, and the proximal urethra, all housed within the pelvic cavity and perineum.
The ureters are muscular tubes that transport urine from the kidneys to the bladder. They enter the pelvic cavity from the abdomen via the pelvic inlet, typically passing anterior to the bifurcation of the common iliac artery. They then course along the lateral pelvic wall and floor to join the bladder base from its posterior superior aspect.
Okay.
For an elite professional, what's particularly fascinating are their specific anatomical relationships and crossings within the pelvis. In men, the ureter is famously crossed by the ductus deferens. In women, it has an even more critical relationship. It is crossed by the uterine artery lateral to the cervix, then continues in close proximity to the lateral vaginal fornix.
So water under the bridge, saying.
Exactly. That uterine artery is the bridge. The ureter is the water. And this leads to an absolutely crucial clinical insight: iatrogenic injury of the ureters. Because of their close proximity to key pelvic structures and dissection planes, the ureters are incredibly vulnerable during pelvic and abdominal surgeries, especially procedures like hysterectomies, salpingo-oophorectomies, or rectal resections.
So surgeons need to be really careful.
Extremely careful. They can be inadvertently crushed, cut, or devascularized, which can lead to severe complications such as hydronephrosis, infection, or renal impairment. Early diagnosis of ureteric injury during surgery is absolutely critical to improve prognosis and prevent long-term morbidity.
The bladder is the most anterior of the pelvic viscera, a muscular, distensible reservoir for urine. When empty, it's entirely contained within the pelvic cavity, but as it fills, it expands superiorly into the abdominal cavity. An empty bladder is typically described as being shaped like a three-sided pyramid, tipped on one of its margins, with an apex, a base, a superior surface, and two inferior lateral surfaces. The apex of the bladder points towards the pubic symphysis and continues superiorly as the median umbilical ligament, which is a remnant of the embryological urachus. The base is an inverted triangular region facing postero-inferiorly. This is where the ureters enter at its upper corners, and the urethra drains from its lower corner. Internally, a key feature is the trigone. This is a smooth, triangular area of mucosal lining on the bladder base, situated between the openings of the ureters and the urethra.
And that trigone doesn't wrinkle up.
Right. Unlike the rest of the bladder mucosa, which is folded and loosely attached, the trigone is firmly attached, which means it doesn't fold when the bladder is empty, making it an important clinical landmark.
The two inferolateral surfaces of the bladder are cradled and supported by the levator ani and obturator internus muscles. The neck of the bladder is its most inferior and fixed part, surrounding the origin of the urethra. It is anchored by tough fibromuscular bands to the pubic bones. These are called the pubovesical ligaments in women and the puboprostatic ligaments in men, where they blend with the prostate capsule.
Right.
Developmentally, it's interesting to note that the bladder is positioned much higher in children, almost entirely abdominal at birth, and only descends to its adult pelvic position after puberty.
For an elite professional, here are some crucial clinical connections related to the urinary system. Bladder stones are calculi that typically form in the kidneys, pass into the bladder, and then can grow larger from the precipitation of salts. They are often associated with problems in bladder emptying or residual urine. These may require transurethral removal or, in some cases, a suprapubic incision.
Right.
Then there's bladder cancer, which is the most common urinary tract tumor, often diagnosed in the 6th to 7th decade, though increasingly seen in younger patients. It's frequently multifocal but superficial initially. It can spread through the bladder wall to local structures like the rectum, uterus, or prostate, and via the internal iliac lymph nodes, though lung metastases are less common. It can also obstruct the ureters, leading to kidney failure. Treatment ranges from local resection and chemotherapy to cystectomy and neobladder reconstruction.
Another important procedure is suprapubic catheterization. When urethral catheterization is impossible or contraindicated, for example, due to an enlarged prostate or urethral injury, a catheter can be placed directly into a full bladder through the anterior abdominal wall. This is typically done about 2 centimeters above the pubic symphysis, guided by ultrasound, providing a crucial alternative for bladder drainage.
A necessary workaround sometimes. And speaking of drainage, let's discuss the urethra, which is the exit channel for urine from the bladder, terminating externally in the perineum. For an elite professional, it's vital to recognize the significant anatomical differences between genders. In women, the urethra is remarkably short, approximately 4 centimeters long, and takes a slightly curved course inferiorly through the pelvic floor into the perineum.
Much shorter.
It opens into the vestibule, just anterior to the vaginal opening. Its inferior aspect is intimately bound to the anterior vaginal surface. It also has 2 small periurethral or skenes, mucus glands associated with its lower end, draining into the vestibule.
Here's a key clinical insight. The short length of the female urethra is a primary reason why women are far more susceptible to bladder infections or cystitis, as bacteria have a shorter distance to travel from the external environment to the bladder.
Makes sense.
In contrast, in men, the urethra is much longer, approximately 20 centimeters, and has 2 distinct, often challenging bends. The first is a fixed angle anteriorly, where it exits the deep perineal pouch into the root of the penis. The second is an inferior curve in a flaccid penis, which straightens out during erection.
For an elite professional, understanding the male urethra's 4 parts is essential for procedures like catheterization. We have the preprostatic part, about 1 centimeters long, extending from the bladder base to the prostate. This section is associated with the internal urethral sphincter, a smooth muscle sphincter that prevents the retrograde movement of semen into the bladder during ejaculation.
Preventing backflow.
Exactly. Then comes the prostatic part, 3 to 4 centimeters long, completely surrounded by the prostate gland. Its lumen features a urethral crest, and on either side are prostatic sinuses where prostatic ducts empty. Mid-length, there's an elevation called the seminal colliculus, where the ejaculatory ducts and the prostatic utricle, a homologue of the uterus, open, effectively connecting the urinary and reproductive tracts.
The membranous part is a narrow, approximately 1–2 centimeters long section that passes through the deep perineal pouch and is surrounded by the skeletal muscle of the external urethral sphincter, which provides voluntary control over urination. Finally, the spongy urethra, or penile part, is the longest segment, entirely surrounded by the erectile tissue of the corpus spongiosum within the penis.
Okay.
It's enlarged at its base, forming the bulb, and again at its end, forming the navicular fossa. The bulbourethral glands open into the bulb of this part of the urethra, and it terminates externally as the external urethral orifice at the tip of the penis.
This complex course in men means urethral catheterization is significantly more involved and technically challenging than in women, who have a much shorter and straighter urethra. Men require careful navigation of these bends in the prostatic and membranous parts, which are particularly vulnerable to damage during procedures like cystoscopy. This highlights why an elite professional needs this detailed anatomical understanding.
Absolutely. Now let's pivot to the reproductive system components within the pelvis. This is where we see some of the most profound anatomical and functional differences between men and women, each with distinct clinical implications.
For men, the reproductive system components are distributed across the abdomen, pelvis, and perineum. Paired structures include the testis, epididymis, ductus deferens, and ejaculatory ducts. Midline structures include the urethra and penis. Additionally, there are crucial accessory glands, a single prostate, paired seminal vesicles, and paired bulbourethral glands.
The testes are fascinating because they develop high on the posterior abdominal wall during fetal development. They normally descend through the inguinal canal into the scrotum before birth, carrying with them their vessels, nerves, lymphatics, and the ductus deferens.
Right, that descent is key.
It is. For an elite professional, this developmental journey has a crucial clinical implication. The lymph drainage of the testes is not to the inguinal or pelvic lymph nodes, as might be expected given their location. Instead, it tracks superiorly to the lateral aortic or lumbar and preaortic nodes situated high in the abdomen, around L1, L2.
That's counterintuitive, but so important.
It's a vital insight for correctly staging and treating testicular cancers, as it dictates where metastatic spread will occur first.
Each ellipsoid testis is enclosed by a tunica vaginalis, which is a closed peritoneal sac. Internally, the testis is composed of highly coiled seminiferous tubules where spermatozoa are produced, along with interstitial tissue, all surrounded by a thick, fibrous capsule called the tunica albuginea. The straight tubules connect to the rete testis, a collecting chamber, and from there, efferent ductules connect to the epididymis.
Here's a critical clinical insight: testicular tumors. While they represent a small percentage of male malignancies, they are particularly common in younger men, typically between 20 and 40 years old. For an elite professional, early diagnosis, often through self-palpation and confirmed by ultrasound, is paramount because most testicular cancers are highly curable with surgery and chemotherapy if detected early.
Good news there.
Yes, if caught early. When surgically removing a malignant testes, an inguinal approach is the preferred method over a scrotal incision. This is a deliberate choice to prevent the potential spread of tumor cells into the scrotal subcutaneous tissues, which, as we noted, have a different lymphatic drainage pattern to inguinal nodes than the testes itself to abdominal nodes.
Another important consideration is ectopic testes, or undescended testes, a condition known as cryptorchidism. This occurs when a testes fails to descend completely and can lie anywhere along its normal developmental pathway, most commonly in the inguinal canal. This condition is more frequently observed in premature births. While watchful waiting may be initially recommended for the first few months, early diagnosis and potential surgical correction called orchiopexy are crucial. This is because undescended testes carry a significantly higher risk of complications, including malignancy, subfertility, testicular torsion, and inguinal hernia, all of which require prompt professional attention.
Right, early intervention is key there. The epididymis is a highly coiled, C-shaped structure located along the posterolateral side of the testis. It consists of efferent ductules that form its head and a single, very long, coiled duct that forms its body and tail. For an elite professional, its function is critical. This is where spermatozoa acquire their full motility and fertilizing ability, and where they are stored until ejaculation. The tail of the epididymis is directly continuous with the ductus deferens.
The ductus deferens, also known as the vas deferens, is a long muscular duct responsible for transporting spermatozoa from the epididymis to the ejaculatory duct. Its course is quite extended. It ascends in the scrotum as part of the spermatic cord, passes through the inguinal canal, and then enters the deep inguinal
It's a
range.
long journey.
It is. From there, it bends medially, crosses the external iliac artery and vein at the pelvic inlet, and descends medially on the pelvic wall, deep to the peritoneum. Crucially, it crosses the ureter posteriorly at the base of the bladder, then continues inframedially along the bladder base, anterior to the rectum. Just before joining the seminal vesicle duct, it expands to form the ampulla.
The ejaculatory duct is then formed by the union of the ductus deferens and the duct of the seminal vesicle. This short duct then penetrates the posterior aspect of the prostate gland to connect with the prostatic urethra, for a simple yet profoundly effective clinical application for an elite professional: vasectomy. This is the surgical division of the ductus deferens, performed bilaterally as a highly effective method of male contraception. Because the ductus deferens is easily palpable and accessible within the spermatic cord in the scrotum, it is a relatively straightforward procedure.
The seminal vesicle is a paired accessory gland of the male reproductive system. It's essentially a blind-ended tubular outgrowth from the ductus deferens, highly coiled and encapsulated, and strategically situated between the bladder and the rectum, just lateral to the ductus deferens at the bladder base. Its duct joins the ductus deferens to form the ejaculatory duct, as we just discussed. Its primary function is to produce and secrete a significant portion of the fluid that contributes to semen volume, providing nourishment and facilitating sperm motility.
Then we have the prostate, a single unpaired accessory gland that plays a central role in the male reproductive and urinary systems. It uniquely surrounds the urethra within the pelvic cavity, positioned inferior to the bladder, posterior to the pubic symphysis, and crucially, anterior to the rectum.
So it's right in the middle of things.
Very much so. Shaped like an inverted rounded cone, its broad base is continuous with the bladder neck, and its apex rests upon the muscular pelvic floor. Its inferolateral surfaces are in direct contact with the levator ani muscles. The prostate develops as 30 to 40 individual glands from the urethral epithelium, which then enlarge the urethral wall. Their individual ducts empty into prostatic sinuses located on the posterior urethral lumen, contributing prostatic fluid to the semen. The ejaculatory ducts also pass through the posterior prostate to join the prostatic urethra.
For an elite professional, prostate health is a major clinical concern, particularly with age. Prostate cancer is the most commonly diagnosed male malignancy. It typically originates in the peripheral zone of the gland and is often asymptomatic in its early stages. Diagnosis often involves a digital rectal examination where a rock-hard consistency may be felt, along with serum acid phosphatase and PSA, prostate-specific antigen tests, followed by ultrasound-guided biopsy.
Right, DRE and PSA are key screening tools.
Prostate cancer can spread locally throughout the pelvis and systemically. In contrast, benign prostatic hypertrophy, BPH, is a very common age-related condition that involves the central regions of the prostate, making it feel bulky rather than hard on DRE. BPH can compress the urethra, causing significant urinary outflow obstruction, which may lead to bladder hypertrophy and, in severe cases, require catheterization.
Another critical clinical consideration for an elite professional is radical prostatectomy, a surgical procedure often performed for prostate cancer. This involves the removal of the prostate and seminal vesicles. A significant potential complication of this surgery is damage to the nerves that arise from the inferior hypogastric plexus, specifically the cavernous nerves, which are crucial for innervating the erectile tissues of the penis.
Ah, the nerves for erection.
Precisely. This damage can lead to impotence or erectile dysfunction. Advancements like robotic prostatectomy aim to meticulously preserve these delicate nerves to minimize such complications.
Finally, the paired bulbourethral glands, also known as Cowper's glands, are small, P-shaped mucus glands located within the deep perineal pouch, positioned laterally to the membranous urethra. Their ducts pass inframedially through the perineal membrane and open into the bulb of the spongy urethra. Their function is to produce a clear, viscous, pre-ejaculatory secretion that helps lubricate the urethra and neutralize any residual acidic urine, preparing the urethra for the passage of semen.
Now let's explore the reproductive system in women. Here, the reproductive tract is primarily housed within the pelvic cavity and perineum, though the uterus famously expands dramatically into the abdominal cavity during pregnancy. The major components include a pair of ovaries, a uterus, vagina, and clitoris as midline structures, plus a pair of greater vestibular glands.
The ovaries, like the tests in males, also develop high on the posterior abdominal wall during fetal life. However, unlike the testes, they descend only to the lateral wall of the pelvic cavity before birth, not passing through the inguinal canal.
So they stay within the pelvis.
Right. As they descend, they bring their vessels, lymphatics, and nerves with them. Their primary function is oogenesis, or egg production. The eggs are then ovulated into the peritoneal cavity and subsequently directed into the uterine tubes. Each almond-shaped ovary, typically around 3 centimeters in length, is suspended by the mesovarium, which is a posterior extension of the broad ligament. The ovarian vessels, nerves, and lymphatics enter the superior pole of the ovary, all enclosed within the suspensory ligament of the ovary, also known as the infundibulopelvic ligament. The inferior pole of the ovary is attached to the uterus by the ligament of the ovary, a fibromuscular band.
For an elite professional, here's a crucial clinical insight into imaging the ovary. Due to its deep pelvic location, ultrasound is the primary modality, either transabdominal, which often utilizes a full bladder as an acoustic window to improve visualization, or transvaginal, which provides a much closer and more detailed view. Laparoscopy also offers direct visualization for diagnostic and therapeutic purposes.
And related to that, ovarian cancer remains a major oncology challenge. For an elite professional, understanding its nature is vital. Tumors most commonly originate from the ovarian surface epithelium and are unfortunately often metastatic at the time of diagnosis, spreading via blood, lymphatics, and directly into the peritoneal cavity, often tracking along the pericolic gutters and over the liver. Family history and older age are recognized risk factors.
A difficult diagnosis often.
Very much so. Another critical condition is ovarian torsion, which is the twisting of an ovary on its vascular pedicle, the suspensory ligament. This compromises its blood supply, initially affecting venous and lymphatic drainage, and then arterial flow, leading to edema, ischemia, and potentially necrosis. It often presents with nonspecific lower abdominal pain and nausea and is more prevalent in women of reproductive age. It's a surgical emergency requiring prompt diagnosis.
The uterus is a thick-walled, pear-shaped muscular organ situated midline in the pelvic cavity, strategically positioned between the bladder anteriorly and the rectum posteriorly. It is primarily composed of 2 main parts, the body and the cervix, with the cervix joining the vagina inferiorly. The 2 uterine tubes project laterally from the superior aspects of the uterine body.
Right.
The body itself is flattened anteroposteriorly, with its rounded superior end known as the fundus. The uterine cavity, a narrow slit in lateral view, appears as an inverted triangle in anterior view, with its superior corners continuous with the uterine tubes and its inferior corner opening into the cervical canal.
For an elite professional, a key functional insight is that normal blastocyst implantation occurs in the uterine body, which then dramatically expands into the abdominal cavity during pregnancy, accommodating fetal growth. In its non-pregnant state, the uterus typically exhibits specific angles. It is normally antiflexed, meaning it arches forward on the cervix, often resting over an empty bladder. The cervix itself is also usually anteverted, angled forward relative to the vagina.
Those angles are important clinically. Here's a crucial clinical insight. Uterine tumors, particularly benign growths known as fibroids or leiomyomas, are very common. They are often asymptomatic, but can cause symptoms such as bloating, increased abdominal girth, and abnormal uterine bleeding. They are often palpable as a mass during physical examination.
Very common indeed.
Diagnosis is typically confirmed by ultrasound or MRI. Treatment options range from conservative management to surgical intervention, such as hysterectomy, surgical removal of the uterus, or less invasive procedures like uterine artery embolization, which aims to reduce blood supply to the fibroids, causing them to shrink.
The uterine tubes, also known as fallopian tubes or oviducts, extend from the superlateral aspects of the uterus to the lateral pelvic wall. They are enclosed within the mesosalpinx, which is a part of the broad ligament, and they typically pass over and terminate lateral to the ovaries. For an elite professional, their 4 main parts are the infundibulum, which is the trumpet-shaped, funnel-like end equipped with finger-like projections called fimbriae that sweep around the ovary and open into the peritoneal cavity. The ampulla, which is the wider segment medial to the infundibulum and is the most common site of fertilization. The isthmus, a narrower, thicker-walled segment that joins the uterus, and finally the uterine part, which is the short segment embedded within the uterine wall.
The fimbriae play a critical role in collecting the ovulated eggs and directing them into the uterine tube for their journey. For family planning, tubal ligation is a simple and highly effective surgical procedure where the uterine tubes are clipped, tied, or severed, preventing sperm from reaching the ovum and thus serving as a permanent method of birth control. Conversely, a critical medical emergency for an elite professional to recognize is an ectopic pregnancy, where implantation of a fertilized egg occurs outside the uterus, most commonly within the fallopian tube. This presents with abdominal pain and a positive pregnancy test, and a ruptured ectopic pregnancy, often within the tube, is a surgical emergency due to life-threatening hemorrhage.
The cervix forms the inferior part of the uterus, appearing as a short, broad cylinder with a narrow central channel. It notably projects into the upper anterior aspect of the vagina. The recess or gutter formed around the margin where the cervix joins the vaginal wall is known as the fornix, which is subdivided into posterior, anterior, and two lateral fornices. The tubular central canal of the cervix has two openings: the external os, which opens into the vaginal cavity, and the internal os, which opens into the uterine cavity.
Here's a critical clinical concern for an elite professional: carcinoma of the cervix uterus. This remains a common disease, particularly in older women, though cervical cancer screening aims to detect it early. Diagnosis involves visual inspection, cytology, such as a pap smear, advanced imaging, and biopsy. Treatment strategies vary depending on the stage and can include local resection, hysterectomy, chemotherapy, and radiation therapy. Lymphatic spread primarily occurs to the internal and common iliac lymph nodes, emphasizing the importance of understanding these drainage pathways for effective staging and management.
The vagina is the female copulatory organ, a distensible fibromuscular tube that extends from the perineum, passes through the pelvic floor, and ascends into the pelvic cavity, with its internal end forming the vaginal vault. Its anterior wall is intimately related to the bladder base and has the urethra embedded within or fused to it, while its posterior wall is related to the rectum.
Close relationships there.
Very close. It opens externally into the vestibule of the perineum, posterior to the urethral opening, and courses posterior-superiorly through the perineal membrane. Its anterior wall is attached to the cervix. Normally, the vaginal canal is collapsed, with its anterior and posterior walls in contact. A speculum is routinely used to visualize the cervix, the fornices, and the external os during gynecological examinations. Functionally, it receives semen during intercourse, facilitating the transport of spermatozoa through the cervical canal, uterine cavity, and uterine tubes for fertilization.
Finally, in women, the greater vestibular glands, also known as Bartholin's glands, are a pair of accessory glands. They are strategically positioned posterior to the bulbs of the vestibule on each side of the vaginal opening within the superficial perineal pouch. For an elite professional, it's important to note that these are considered the female homologs of the bulbourethral glands in men, although their exact anatomical location differs.
Ah, interesting placement difference.
Yes. Their ducts open into the vestibule along the posterolateral margin of the vaginal opening, and their primary function is to produce a lubricating secretion during sexual arousal.
Now, let's explore how everything is organized and effectively contained within this complex region. We're talking about fascia and peritoneum, the wrapping and draping layers that support and separate structures.
Pelvic fascia is essentially a continuation of the extraperitoneal connective tissue that extends down from the abdomen. For an elite professional, it's helpful to think of it as the body's internal shrink wrap and scaffolding. It meticulously lines the pelvic walls, surrounds the bases of the pelvic viscera, and forms crucial sheaths for the vessels and nerves as they course medially from the pelvic walls to reach their target organs in the midline. It's not just passive packing material, it actively organizes and supports.
In women, the pelvic fascia has specific and clinically relevant condensations. A rectovaginal septum separates the posterior aspect of the vagina from the anterior wall of the rectum. Even more crucial are the fascial ligaments that provide critical stability to the uterus. The pubocervical ligament extends from the cervix to the anterior pelvic wall. The uterosacral ligament runs from the cervix, the posterior pelvic wall, and most importantly, the transverse cervical cardinal ligament, which extends robustly laterally from the cervix and vaginal vault to the lateral pelvic wall.
The cardinal ligament is key support.
Absolutely. These ligaments, along with the perineal membrane and levator ani muscles, collectively stabilize the uterus within the pelvic cavity, preventing prolapse.
In men, we see similar fascial organization. There is a dense prostatic fascia, which is a condensation of connective tissue that encases the anterior and lateral regions of the prostate gland. This fascia not only provides structural support, but also contains and surrounds the rich prostatic plexus of veins. Posteriorly, this prostatic fascia is continuous with the rectovesical septum, a fibrous sheet that separates the posterior surface of the prostate and the bladder base from the anterior wall of the rectum.
Next, the pelvic peritoneum is a continuous serient membrane with the abdominal peritoneum, entering the pelvis at the pelvic inlet. It doesn't fully invest the pelvic organs, but rather drapes over them, creating distinct pouches, folds, and ligaments. This draping pattern is crucial for understanding fluid collection and the spread of infection.
In women, because the uterus is situated centrally between the bladder and rectum, the peritoneum forms two distinct pouches. Anteriorly, there's a shallow space called the vesicouterine pouch, located between the bladder and the uterus. Posteriorly, and much more clinically significant, is the deep rectouterine pouch, famously known as the pouch of Douglas, situated between the uterus and the rectum.
The pouch of Douglas, yes.
For an elite professional, this pouch of Douglas is critically important because it is the lowest portion of the abdominopelvic cavity when a person is in a supine position. This makes it a common site for the collection of fluid, blood, or infection, and it can be clinically examined via transvaginal or transrectal palpation, or even drained in procedures like choledocentesis.
Furthermore, in women, a large sheet-like fold of peritoneum, known as the broad ligament, extends from the lateral pelvic wall to the uterus on each side. It encloses the uterine tube within its superior margin and suspends the ovary from its posterior aspect via the mesovarium. It's also important for an elite professional to remember that the uterine arteries crucially cross the ureters at the very base of this broad ligament.
That crossing point again?
The broad ligament itself is anatomically divided into three parts: the mesometrium, which is the largest part extending from the lateral pelvic walls to the uterus, the mesosalpinx, which suspends the uterine tube, and the mesovarium, which attaches to the ovary. Sharp, sickle-shaped peritoneal ridges, called rectouterine folds, are also present near the base of the rectouterine pouch, overlying the uterosacral ligaments.
In men, the peritoneum forms a single, deeper space known as the rectovesical pouch, situated between the bladder and the rectum. Anteriorly, in both sexes, we observe the median and medial umbilical folds, which cover the remnants of the urachus and the umbilical arteries, respectively. Posteriorly, the peritoneum drapes over the anterior and lateral aspects of the upper third of the rectum, covers only the anterior surface of the middle third, and importantly does not cover the lower third at all. This differential draping is a key anatomical detail for understanding the patterns of fluid collection and the spread of inflammatory processes in the pelvic region.
Now let's unravel the wiring system. Nerves of the pelvis and perineum. This intricate network is absolutely vital for the sensory, motor, and autonomic functions of this entire region.
We'll begin with the somatic plexuses, specifically the sacral and coccygeal plexuses. These nerve networks are strategically situated on the posterolateral wall of the pelvic cavity, nestled between muscles and blood vessels. They are primarily formed by the ventral rami of spinal nerves S1 to coccygeal, with crucial contributions from L4 and L5 via the lumbosacral trunk. Their collective function is to innervate the muscles and skin of the lower limb, as well as the pelvic and perineal muscles and most of the skin of the perineum.
The sacral plexus itself is robustly formed by the anterior rami of S1, S4 and the lumbosacral trunk, L4, L5. It forms in close relation to the anterior surface of the piriformis muscle, which is a key anatomical landmark. From this plexus, several major nerves emerge. The sciatic nerve, L4S3, is the largest nerve in the entire body.
Huge nerve.
It forms on the anterior surface of the piriformis muscle and then leaves the pelvis via the greater sciatic foramen, specifically passing inferior to the piriformis. It then descends into the thigh, eventually dividing into the common fibular and tibial nerves, innervating the posterior thigh, leg, and foot muscles, and providing sensory innervation to the foot and lateral leg.
For an elite professional, here's a critical clinical insight. Sciatic nerve compression. A mass in the pelvis, for example, a nerve tumor, or even muscle hypertrophy like piriformis syndrome, anterior to the piriformis, can compress the sciatic nerve. This compression can cause significant pain, often described as radiating from the gluteal region down the posterior thigh, leg, and foot, along with muscular weakness that can manifest as foot drop. Understanding the precise course of the sciatic nerve relative to these pelvic structures is paramount for accurate diagnosis and treatment of such conditions.
Then we have the pudendal nerve, S2, S4, which is arguably the most important nerve of the perineum. It forms anterior to the lower piriformis muscle, leaves the pelvis via the greater sciatic foramen, again, inferior to the piriformis, and then performs that fascinating anatomical loop. It curls around the sacrospinous ligament and the ischial spine, only to re-enter the perineum via the lesser sciatic foramen, accompanied by the internal pudendal vessels.
That loop again.
This nerve is responsible for innervating the skin and all the skeletal muscles of the perineum, including the crucial external anal and urethral sphincters, as well as the levator ani muscles.
The pudendal nerve has three crucial branches that an elite professional must know. The inferior rectal nerve supplies the external anal sphincter, parts of the levator ani, and the skin of the anal triangle. The perineal nerve provides motor innervation to the superficial and deep perineal pouch muscles and sensory innervation via the posterior scrotal or labial nerves. Finally, the dorsal nerve of the penis clitoris provides crucial sensory innervation to the glands and body of the penis or clitoris.
Okay.
Here's another critical clinical application: a pudendal block. This is a regional anesthesia technique frequently used for childbirth, chronic pelvic pain management, or certain rectal and urological procedures. The anesthetic is injected near the ischial spine, where the nerve famously crosses the sacrospinous ligament, making that palpable landmark absolutely vital for accurate placement.
Other important somatic nerves from the sacral plexus include the superior gluteal nerve, L4-S1, which leaves above the piriformis to supply the gluteus medius, minimus, and tensor fasciae latae, and the inferior gluteal nerve, L5-S2, leaving below the piriformis to supply the gluteus maximus. Nerves to the obturator internus and superior gemellus, quadratus femoris, and inferior gemellus, posterior femoral cutaneous, and perforating cutaneous nerves also arise from this plexus. Importantly, direct branches from the S4 spinal nerve provide primary innervation to the levator ani and coccygeus muscles.
A distinct nerve, the obturator nerve, L2-L4, is actually a branch of the lumbar plexus. It passes along the posterior abdominal wall, emerges from the psoas major muscle, crosses the pelvic inlet posterior to the common iliac artery and medial to the internal iliac artery, and then leaves the pelvis via the obturator canal to supply the adductor compartment of the thigh.
So it just passes through the pelvis, really.
Essentially, yes. The small coccygeal plexus, formed mainly by S5 and co with a minor S4 contribution, gives rise to the anacoccygeal nerves that innervate the perianal skin. Additional sensory branches from the ilioinguinal, genitofemoral, and posterior femoral cutaneous nerves also contribute to the sensory innervation of the perineum.
Moving to the visceral plexuses, these carry the autonomic and visceral afferent fibers that control the internal organs and erectile tissues. The inferior ends of the paravertebral sympathetic chains enter the pelvis over the sacral ala. They course along the anterior surface of the sacrum, forming typically 4 ganglia on each side, and ultimately join anterior to the coccyx at a single midline ganglion impar. Their primary function in this region is to deliver postganglionic sympathetic fibers to the sacral anterior rami via gray rami communicantes, innervating the blood vessels and periphery of lower limb and perineum. Additionally, sacrosplanchic nerves contribute to the pelvic prevertebral plexus.
The pelvic extensions of the prevertebral plexus are crucial, carrying a complex mix of sympathetic, parasympathetic, and visceral afferent fibers. These highly integrated plexuses innervate all the pelvic viscera and the perineal erectile tissues. They begin as the superior hypogastric plexus, situated anterior to L5, between the sacral promontory and the aortic bifurcation. From here, fibers separated to 2 hypogastric nerves, which then descend into the pelvis.
Okay.
Within the pelvis, these hypogastric nerves are joined by the pelvic splanchnic nerves, which carry parasympathetic fibers from S2-S4, to form the paired pelvic plexuses, also known as the inferior hypogastric plexuses, situated on each side of the rectum. These extensive plexuses then give rise to numerous subsidiary plexuses, including the rectal, uterovaginal, prostatic, and vesical plexuses. Their terminal branches, known as cavernous nerves in men, arising from the prostatic plexus, specifically innervate the erectile tissues of the penis.
The sympathetic fibers, which originate from spinal cord segments T10-L2, play several key roles here. They primarily innervate blood vessels, causing vasoconstriction. They also cause the contraction of smooth muscle, such as the internal urethral sphincter in men, preventing retrograde ejaculation, and the internal anal sphincters in both sexes, contributing to continence. Furthermore, they stimulate smooth muscle contraction in the male reproductive tract and accessory glands, which is absolutely crucial for moving secretions from the epididymis and glands into the urethra during ejaculation.
For an elite professional, understanding the interplay of the autonomic nervous system is critical for male sexual function, particularly emission and ejaculation. Emission, the process of forming semen by moving spermatozoa and glandular secretions into the prostatic urethra, is primarily driven by sympathetic contraction of ducts and glands. T12, L12 spinal cord levels. Ejaculation, the forceful expulsion of semen from the urethra, is a reflex action largely caused by the rhythmic contraction of the bulbospongiosus muscle, which is supplied by the pudendal nerve, S2S4.
Okay, so sympathetic for emission, pudendal for ejaculation.
Broadly, yes, and crucially, the simultaneous contraction of the internal urethral sphincter, it's a sympathetic innervation, prevents the retrograde ejaculation of semen into the bladder.
The parasympathetic fibers, originating from spinal cord segments S2, S4, and traveling via the pelvic splanchnic nerves, generally have opposing effects to the sympathetics. They are typically vasodilatory, promoting increased blood flow. They stimulate the contraction of the detrusor muscle in the bladder wall, which is essential for urination. And critically, they are responsible for stimulating erection in both men and women, with the parasympathetic nerves penetrating the deep perineal pouch to reach the erectile tissues. They also modulate the enteric nervous system of the colon distal to the left colic flexure, influencing bowel motility.
For an elite professional, here's a crucial clinical connection. Erectile dysfunction, ED. This complex condition, defined as the inability to achieve or maintain an erection firm enough for satisfactory sexual intercourse, is often multifactorial. Causes can include vascular impairment, nerve damage from age, cardiovascular disease, diabetes, neurological conditions, or nerve injury during pelvic surgeries, radiation, low testosterone levels, and significant psychological factors.
So it's rarely just one thing.
Very often not. Similar vascular and nerve compromises can affect vulvar swelling and arousal in women, though this is less frequently a symptomatic complaint that leads to medical consultation.
Finally, visceral afferent fibers transmit sensory information, including pain, from the pelvic viscera back to the spinal cord. These fibers follow both sympathetic pathways, carrying pain from lower thoracic lumbar levels, particularly from upper pelvic organs that developed higher in the abdomen, and parasympathetic pathways, carrying pain from organs like the cervix and parts of the bladder and urethra to sacral levels.
Right, different pathways for pain.
Another critical clinical insight emerges here. During a radical prostatectomy, damage to the delicate nerves from the inferior hypogastric plexus that innervate the erectile tissues can cause profound impotence. Similarly, nerve damage during extensive pelvic surgery in women, such as a hysterectomy or rectopexy, can lead to various forms of sexual dysfunction, highlighting the immense precision required in these surgical fields.
Now let's trace the intricate network of supply lines, the blood vessels of the pelvis and perineum. Understanding this vascular architecture is fundamental for both normal physiological function and clinical pathology.
The major artery supplying the pelvis and perineum is the internal iliac artery on each side. It originates from the common iliac artery at the level of the L5S1 vertebral body and then typically divides into an anterior and a posterior trunk. The posterior trunk branches primarily supply the lower posterior abdominal wall, the posterior pelvic wall, and the gluteal region. These include the iliolumbar artery, which ascends out of the pelvic inlet to supply abdominal wall muscles, psoas, quadratus lumborum, cauda equina, and iliac fossa. The lateral sacral arteries, usually two, supplying bone, soft tissues, vertebral canal structures, and posterior sacrum, and the superior gluteal artery, which is the largest branch and often the terminal continuation of the posterior trunk, leaving via the greater sciatic foramen above the piriformis to supply the gluteal muscles and skin.
The anterior trunk branches of the internal iliac artery are more numerous and supply a wider array of structures, including the pelvic viscera, the perineum, parts of the gluteal region, and the adductor region of the thigh. These branches include the umbilical artery, which is typically the first branch and gives off the superior vesical artery, supplying the superior bladder and distal ureter, and in men, sometimes the ductus deferens, before becoming the fibrous medial umbilical ligament after birth.
The remnant ligament, yeah.
The inferior vesical artery, found in men, supplies the bladder, ureter, seminal vesicle, and prostate. Its functional equivalent in women is the vaginal artery, which supplies the vagina and adjacent bladder and rectum. It may originate independently or with the uterine artery. The middle rectal artery supplies the rectum and forms important anastomoses with the superior rectal artery from the inferior mesenteric artery and the inferior rectal artery from the internal pudendal artery.
Then we have the obturator artery, which courses along the pelvic wall and exits the pelvis via the obturator canal to supply the adductor region of the thigh. The internal pudendal artery is a critical vessel for the perineum. It courses inferiorly, leaves the pelvis via the greater sciatic foramen, inferior to the piriformis, loops around the sacrospinous ligament and ischial spine, and then re-enters the perineum via the lesser sciatic foramen. It is, in fact, the main artery of the perineum.
The branches of the internal pudendal artery closely mirror those of the pudendal nerve.
Yeah.
These include the inferior rectal arteries, which cross the ischioanal fossa to supply the external anal sphincter and the muscles and skin of the anal triangle, anastomosing with the middle and superior rectal arteries. The perineal artery gives off the transverse perineal branch and the posterior scrotal or labial artery.
Okay.
Its terminal branches in the deep perineal pouch are vital for the erectile tissues. These are the artery to the bulb of the penis, or vestibule in women, which supplies the corpus spongiosum, or bulb of vestibule and vagina, the urethral artery supplying the peni urethra and surrounding erectile tissue up to the glands, the deep artery of the penis clitoris, which penetrates the perineal membrane to enter the crus and supply the crus and corpus cavernosum, and the dorsal artery of the penis clitoris, which penetrates the anterior perineal membrane to run along the dorsal surface of the penis clitoris body, supplying the glands, superficial tissues, and anastomosing with the deep artery.
Other interior trunk branches include the inferior gluteal artery, a large terminal branch that also leaves via the greater sciatic foramen, inferior to the piriformis, to supply the gluteal region and contribute to anastomosis around the hip joint. In women, the uterine artery is particularly significant. It courses medially and anteriorly within the base of the broad ligament and, as we've noted, crucially crosses superior to the ureter.
Water under the bridge again.
Exactly. It then ascends laterally along the uterus, providing its major blood supply and anastomosing with the ovarian artery. It dramatically enlarges during pregnancy. Also, the median sacral artery originates from the posterior aorta at the L4 level, descending in the midline along the anterior sacrum and coccyx, giving off lumbar arteries and anastomosing with the iliolumbar and lateral sacral arteries. In women, the ovarian arteries originate directly from the abdominal aorta, descend, and cross the pelvic inlet within the suspensory ligament of the ovary. They supply the ovaries and anastomose with the uterine artery, also enlarging significantly during pregnancy.
Beyond the internal iliac system, we also have the external pudendal arteries, which are superficial and deep vessels branching from the femoral artery. They course medially into the perineum, supplying the skin of the penis and scrotum in men, or the clitoris and labia majora in women. In men, the testicular arteries originate from the abdominal aorta and descend into the scrotum via the inguinal canal, while the cremasteric arteries branch from the inferior epigastric artery and accompany the spermatic cord. In women, small cremasteric arteries follow the round ligament through the inguinal canal.
Here's a crucial clinical insight for an elite professional: left common iliac artery obstruction. A blockage in the left common iliac artery prevents normal blood flow to both the internal and external iliac arteries on that side. This can cause ischemic pain in the buttock, a condition known as intermittent claudication, which is pain that occurs during exercise and resolves with rest.
Right, pain on walking.
Critically, it can also lead to impotence in men due to reduced blood supply from the internal pudendal artery, which arises from the internal iliac artery. This condition is often associated with smoking and can be treated with lifestyle modifications, angioplasty, or bypass graft surgery.
Turning to the veins, most pelvic veins generally follow the branches of the internal iliac artery, eventually draining into the internal iliac veins, which then join with the external iliac veins to form the common iliac veins. Within the pelvic cavity, there's an extensive and interconnected network of venous plexuses associated with the bladder, rectum, prostate, uterus, and vagina, collectively known as the pelvic plexus of veins.
The rectal venous plexus is particularly noteworthy because of its dual drainage pathways. Blood from this plexus drains both into the hepatic portal system via the superior rectal veins, which empty into the inferior mesenteric vein, and into the caval system via the middle and inferior rectal veins, which empty into the internal iliac veins. This dual drainage forms an important porticaval shunt, which provides a collateral pathway for blood return when the hepatic portal system is obstructed, for example, in conditions like liver cirrhosis.
A critical bypass route.
Enlargement of the internal rectal plexus, located in the connective tissue between the internal anal sphincter and epithelium, superior to the pectinate line, causes internal hemorrhoids, while enlargement of the subcutaneous external rectal plexus, which circles the external anal sphincter, causes external hemorrhoids.
What's fascinating here is the unique drainage pattern of the deep dorsal vein of the penis clitoris. It drains the glands and corpora cavernosa, but critically, it does not follow the branches of the internal pudendal artery. Instead, it passes directly into the pelvic cavity through a gap between the arcuate tubic ligament and the perineal membrane, connecting with the prostatic plexus in men or the vesical plexus in women.
So it takes its own route.
It does. The superficial veins of the penis or clitoris, which drain the skin, are tributaries of the external pudendal veins, which in turn connect with the femoral vein. The median sacral veins coalesce and typically join the left common iliac vein, or the common iliac vein junction, and the ovarian veins follow their respective arteries, with the left ovarian vein joining the left renal vein and the right ovarian vein joining the inferior vena cava.
Finally, let's explore the lymphatic network, which is the critical drainage system of the pelvis and perineum. For an elite professional, understanding these pathways is absolutely essential for diagnosing and staging cancers and infections in this region.
Lymphatics from most pelvic viscera primarily drain into lymph nodes strategically located along the internal iliac and external iliac arteries and their branches. These then coalesce and drain into the common iliac nodes, which in turn drain into the lateral aortic or lumbar nodes situated around the abdominal aorta. From there, the lymph ultimately flows into the lumbar trunks, eventually emptying into the thoracic duct, typically around the level of the 12th thoracic vertebra, or T12. This hierarchical drainage pattern is fundamental for understanding metastatic spread.
However, the ovaries and related parts of the uterus and uterine tubes have a slightly different and highly significant lymphatic pathway. Their lymphatic vessels leave the pelvic cavity superiorly, accompanying the ovarian arteries, and drain directly into the lateral aortic or lumbar nodes, and sometimes the pre-aortic nodes, located high in the abdomen, typically around the L1, L2 vertebral levels. This direct connection bypasses the typical pelvic node chain, which is a crucial distinction for oncological staging.
A key difference for ovarian cancer spread is the gluteal region and the deep perineum largely drain into the lymph nodes situated along the internal iliac artery. For specific perineal drainage, the deep parts of the perineum follow the internal pudendal vessels and primarily drain into the internal iliac nodes. In contrast, the superficial tissues of the penis or clitoris and the scrotum or labia majora tend to accompany the superficial external pudendal vessels and drain mainly into the superficial inguinal nodes.
So superficial structures go to superficial nodes.
Generally, yes.
Yeah.
The glans penis, glans clitoris, labia minora, and the terminal inferior vagina have a slightly deeper drainage, connecting with the deep inguinal nodes and the external iliac nodes.
Here's the absolute crucial insight for you as an elite professional, one that often distinguishes a comprehensive understanding: the testes lymphatic drainage anomaly. The lymphatic channels from the testes ascend in the spermatic cord, pass through the inguinal canal, and track directly up the posterior abdominal wall. They connect exclusively with the lateral aortic or lumbar nodes and the pre-aortic nodes, located high in the abdomen, around the L1, L2 vertebral levels.
Straight up the abdomen.
This means that any disease originating in the testes, particularly cancer, will track superiorly to these high abdominal nodes, not to the inguinal or iliac nodes in the pelvis. This understanding is paramount for correctly staging and managing testicular cancer, as it dictates the primary sites of metastatic spread.
To conclude our deep dive, let's bring all this intricate anatomical knowledge into practical context by briefly reviewing surface anatomy and clinical landmarks. These are the palpable points that allow an elite professional to orient themselves externally to the complex internal structures.
In the anatomical position, it's crucial to visualize that your anterior superior iliac spines and the superior edge of the pubic symphysis actually lie in the same vertical plane. This dictates that the pelvic inlet faces anterosuperiorly. In the perineum, the urogenital triangle is oriented almost horizontally, facing inferiorly, while the anal triangle is more vertical, facing posteriorly. Developing this spatial awareness is foundational for any clinical assessment.
To define the external margins of the perineum, especially when a patient is in the lithotomy position, lying on their back with thighs flexed and abducted, several landmarks are easily palpable. The ischial tuberosities, or the large bony masses you can feel near the gluteal fold, marking the lateral corners of that diamond-shaped perineum. The cossyphax tip is palpable midline posteriorly, serving as the most posterior limit. The pubic symphysis forms the anterior limit. In women, it's deep to the mons pubis, and in men, superior to the base of the penis.
Okay.
Imaginary lines connecting these landmarks outline the perineum, and a horizontal line drawn between the ischial tuberosities divides it into the urogenital and anal triangles, with the midpoint of this line approximating the location of the perineal body.
In the anal triangle, the major and most obvious feature is the anal aperture located centrally. It is flanked on each side by the fat-filled ischio-anal fossae. For an elite professional, these soft, pliable regions packed with adipose tissue are important to note, as they allow for the necessary movement and expansion of the anal canal during defecation without causing internal friction or damage.
For identifying structures in the urogenital triangle in women, the collective external genitalia is known as the vulva, which includes the clitoris, vestibule, and the skin folds of the labia. The labia minora are two thin skin folds that enclose the vestibule, which is the space containing the urethral and vaginal openings. The openings of the periurethral Skene's glands are found near the urethra, and the vaginal opening, or introitus, may be partially ringed by hymen remnants. The ducts of the greater vestibular Bartholin's glands open into the skin crease between the hymen and labium minus. The labia minora also bifurcate interiorly. The medial folds form the frenulum of the clitoris, while the lateral folds form the prepuce or hood of the clitoris. They join posteriorly to form the fourchette. The broader labia majora are folds lateral to the labia minora. They unite anteriorly at the mons pubis and are separated posteriorly by the posterior commissure overlying the perineal body. The glans clitoris is visible under its hood, and its body is palpable deep to the prepuce. Deep to the labia minora, the erectile tissues of the bulbs of the vestibule are located, continuous with the glans clitoris. Through a speculum examination, the cervix is directly visible in the vaginal canal, including its external O's and the surrounding fornices, anterior, posterior, and lateral.
And for men, in the urogenital triangle, we examine the scrotum and penis. The scrotum, which is the male homologue of the labia majora, contains the palpable oval testes. Posterolateral to the testes, you can feel the elongated mass of the epididymis, along with the ductus deferens, vessels, nerves, and lymphatics of the spermatic cord. A midline raphe is visibly present on both the scrotum and the ventral aspect of the penis. The root of the penis is palpable posterior to the scrotum. The bulb of the penis, which is the attached part of the corpus spongiosum, is a large, palpable mass situated anterior to the perineal body and covered by the bulbus spongiosus muscles. The crura of the penis, which are the attached parts of the corpora cavernosa, are anchored to the ischiopubic rami. The body of the penis, or shaft, is covered by skin, and its expanded distal end is the glans penis. The external urethral orifice is a sagittal slit at the tip of the glans. The frenulum of the glans is a median fold of skin attaching the glans to the looser skin of the shaft, and a raised circular margin at the base of the glans is called the corona of the glans. The prepuce, or foreskin, is the fold of skin that covers the glans in uncircumcised males. You've just completed an incredible deep dive into the pelvis and perineum. From the supportive bony rings and intricate muscle slings that form its walls and floor, to the delicate interplay of the urinary, gastrointestinal, and reproductive systems housed within, and the complex network of nerves and vessels that bring it all to life. We've explored not just the structures, but their vital functions and profound clinical implications, giving you an elite professional's understanding.
Indeed. You now understand why the pelvis is truly a central crossroads of the body. You've grasped how its unique anatomy in men and women dictates different susceptibilities to conditions like bladder infections or complications in childbirth, and the critical importance of landmarks like the ischial spine for clinical procedures.
Yeah.
The way embryology dictates the unique lymphatic drainage of the testes, or how a simple pelvic fracture can lead to life-threatening complications, highlights the depth of knowledge we've uncovered today, designed for mastery.
This isn't just academic knowledge. It's a toolkit for better understanding your own body, appreciating the precision required in medicine, and perhaps even sparking further curiosity about the human form. You now have a foundational grasp, much like an elite professional in the field, of this essential region.
So, as you reflect on this, consider this provocative thought. How many of the conditions we discussed today, from prostate problems and uterine fibroids to erectile dysfunction and pelvic organ prolapse, are becoming more prevalent with an aging global population? How might our growing, in-depth understanding of this complex anatomy continue to revolutionize preventative care, diagnostic techniques, and treatment strategies in the coming decades, allowing us to maintain health and quality of life longer than ever before? This fundamental knowledge truly is the gateway to future innovations in a field that continues to evolve rapidly.